So the FAME2 trial was conducted in order to answer a very relevant question, whether PCI in patients with stable coronary artery disease, as guided by fractional flow reserve, has an additional advantage over medical therapy alone. So for the first time when the study began to enroll patients, this was done. Every single lesion was assessed by FFR, and this was the novel aspect of the study, and at the same point, a very key point for the understanding of the results of the trial, the physiology behind the trial and the assessment of every single lesion that deemed to be angiographically significant on coronary angiography. The study design was as follows. Patients that had stable coronary artery disease or atypical angina or even silent ischemia that was documented with non-invasive testing came to the cath lab and had coronary angiographies. If a lesion of at least 50% diameter stenosis was found, then this lesion was measured by means of FFR. And this is the critical point of the study. Based on these FFR values, patients were stratified according to the presence, if you want, of ischemia. So in case of a patient having non-ischemic lesions throughout his coronary tree, he was versed into a registry. However, if at least one significant lesion was found, meaning that FFR value was equal or less than 0.8, then the patient was randomized to either receive PCI plus medical therapy or medical therapy alone. And these patients were followed up to 5 years. The main findings of the study, and this is the final 5-year report of the study, were as follows. First, the primary endpoint was a composite of all-cause death, myocardial infarction, and urgent revascularizations. And it has been proven that PCI, as guided by FFR, results in low event rates, and these event rates in the patients that had ischemic lesions treated by PCI were comparable to the registry patients, meaning patients that did not have hemodynamically significant lesions. In contrast, the patients that were offered medical therapy alone had a worse event rate as compared to the PCI patients. What is novel is that this primary endpoint is not only driven by urgent revascularizations, but there's also a clear signal towards lower myocardial infarction rate in the PCI group. And this is something which is novel for this study. This is mainly driven by spontaneous myocardial infarctions in the total myocardial infarction population. And this is a novel aspect that should be actually have our attention and merit further, let's say, studies on that. ORBITA was a very innovative trial in the sense that it had double blinding, and this is something novel for the field. We start to see similar trials coming up for electrophysiology as well, and I refer to the Cabana trial, and both of these trials have come up with very provocative results. Coming back to ORBITA, this trial assessed stable coronary artery disease patients. In contrast to our study, ORBITA was double-blinded, and today we were able to hear the outcomes of the study as regards the FFR and IFR evaluation of these lesions. What ORBITA essentially presents is a disconnect between angina, symptoms that is, and ischemia. I don't feel that these two trials are necessarily opposed. ORBITA proved that a PCI actually confers a clinical advantage to patients. FAME2 says the same thing. We speak now about hard endpoints, meaning myocardial infarction. The question of whether angina is something which is easily or very difficultly assessed remains to be proven. Of course, and I would like to stress that, double-blind trials provide us with insights that we did not have up to now. What should be essentially kept in mind is that physiology-guided revascularization should be the norm. We have compelling data to support this statement, not only from the FAME trials, but also from real-life registries, meta-analysis, and so on and so forth. So coronary angiography should be a thing of the past, if not accompanied by physiology-guided evaluation of lesions. We are now at an era that we are not only able to measure FFR with a guide wire, but also do that non-invasively, meaning that we don't have to wire the lesion. And this is the wave of the future. Further research in this area should definitely take into account placebo-controlled trials. We have results that are thought-provoking, and I think that we will see a surge of trials that have incorporated non-invasive, non-wire-based FFR measurements, and this should speak in favor of physiology-guided procedures in the future. We remain, let's say, a bit curious to see if these trials that use QFR or other similar technologies or FFRCT will live up to the promise and be translated into better clinical outcomes in the years to come.